All right, welcome to this explainer on mastering the high-stakes timeline of diabetic ketoacidosis management in the ED. We're basing this directly on the 2024 ADA consensus guidelines. Look, when a patient rolls through your doors in a DKA crisis, you're basically fighting a multi-front metabolic war. Every single minute matters. The decisions you make in those first few hours, they can literally mean the difference between a rapid, smooth recovery and a lethal complication. So today, we're going to break down the absolute latest cutting-edge protocol to give you a totally bulletproof mental framework for your next shift. Let's get into it.
Here is our roadmap for managing this critical timeline. We'll kick things off with diagnosing the DKA crisis, then move to the first 30 minutes, into Phase 1, fluid resuscitation, Phase 2, potassium and insulin, and we'll wrap up with resolution and common pitfalls.
Section 1. Diagnosing the DKA crisis, identifying the metabolic derangement. To officially confirm DKA, you need all three elements of the updated diagnostic triad. First up, hyperglycemia. This is typically defined as a blood glucose over 200 to 250. Second is metabolic acidosis, meaning a venous pH under 7.3 or a serum bicarb under 18. And third, ketosis. Now, the 2024 guidelines strongly recommend bedside point-of-care testing for beta-hydroxybutyrate. We're looking for a level of 3.0 or higher. Actually, scratch the old-school urine ketones. Beta-hydroxybutyrate gives you a much faster, far more accurate picture of the patient's current metabolic state in real time.
But here is where you really have to stay sharp. Crucially, do not rule out DKA on glucose alone. There's a dangerous trap out there called euglycemic DKA, and it requires a super high index of suspicion. In euglycemic DKA, the patient's blood glucose is actually under 200, which makes it incredibly easy to misdiagnose if you aren't paying close attention. This sneaky presentation is often triggered by medications like SGLT2 inhibitors, as well as pregnancy, prolonged fasting, or chronic liver disease. The bottom line? If the patient is acidotic and ketotic, do not let a normal blood sugar blind you to the crisis right in front of you.
Once we confirm the diagnosis, we need to quickly stratify the severity into mild, moderate, or severe. We do this based on specific pH, bicarbonate, and mental status thresholds. For mild DKA, the pH sits between 725 and 730, and the patient's fully alert. Moderate DKA drops that pH to the 700 to 724 range, and you might notice they're a bit drowsy. But severe DKA, that's a pH tanking under 7.0, bicarbonate crashing below 10, and a patient who may actually be in a stupor or even a coma. Stratifying this instantly tells you exactly how aggressively you need to mobilize your ED resources.
Section 2. The first 30 minutes, the initial workup.
This timeline is all about the rapid-fire testing needed to get ahead of the metabolic cascade. The clock is ticking. At T0, you're grabbing that point-of-care glucose and beta-hydroxybutyrate. By minute 10, you're sending off a venous blood gas and a BMP. Notice I said venous blood gas. Arterial 6 are rarely needed here and just cause the patient unnecessary pain. By minute 20, you absolutely must secure a baseline ECG. Why? Because you are actively hunting for peaked T waves of hyperkalemia or flattening U waves of hypokalemia before a single drop of insulin is given. Finally, by minute 30, get an accurate patient weight for precise dosing and do your first neurocheck.
And as you're staring at those first labs coming back, keep this in mind. Measured sodium is falsely lowered by hyperglycemia. You always have to calculate the corrected sodium to guide your fluid choices. Think about it like this. The osmotic pull of all that extra glucose draws water right out of the cells and into the bloodstream, which dilutes your serum sodium. If you just trust the raw number on the lab sheet, you're going to be misled. Using this corrected sodium formula is an absolute must for the next step of our protocol.
Section 3. Phase 1. Fluid resuscitation. Reversing the deficit.
Okay, so DKA patients usually have a massive intravascular deficit. We're talking liters here. We manage this in 3 precise steps. Step 1, you blast them with an initial isotonic saline bolus at 15 to 20 mL per kilo per hour. For a standard adult, that's roughly a liter to a liter and a half in the very first hour. Step 2 is where that corrected sodium we just talked about comes into play. After the bolus, if the corrected sodium is normal or high, you switch to half-normal saline to dodge hypernatremia. If it's low, stick with normal saline. Then step 3 is the pivot. The exact second the blood glucose falls into that 200 to 250 range, you must add dextrose to the IV fluids. We do this so we can keep the insulin running to clear out the acidosis without totally crashing their blood sugar.
Now here's a really interesting development.
While normal saline is the traditional standard, recent meta-analysis are showing that balanced crystalloids, think lactated ringers or plasmolite, might resolve DKA up to 5 hours faster. 5 hours! That's huge! Pumping a patient full of normal saline often triggers a hyperchloremic non-anion gap acidosis, which just muddies the clinical waters and delays resolution. Using balanced crystalloids bypasses that whole mess entirely. It's a really compelling alternative depending on what your institutional protocols allow.
Section 4. Phase 2. Potassium and insulin. The high-stakes dance.
Let's dive into the absolute most dangerous phase of the protocol. Timing here is literally a matter of life and death. I need you to burn this number into your brain. 3.3. If potassium is under 3.3, then you absolutely must hold insulin and replete the potassium first to prevent lethal arrhythmias. Remember, total body potassium is severely depleted in DKA, even if the serum level looks perfectly normal, because the acidosis shifts potassium outside the cells. The moment you push insulin, it violently drives that potassium right back in. If they're already starting under 3.3, insulin will plunge them into profound heart-stopping hypokalemia. Hold the insulin, give IV potassium, wait until they cross back over 3.3. No exceptions.
As for the insulin itself, the 2024 update makes a huge change. Omit the old initial bolus dose and go straight to the steady infusion. For years, we were all taught to hit them with a 0.1 unit per kilo bolus right up front. Well, the latest consensus says, skip it. It's just not routinely recommended anymore. Simply start your regular IV insulin infusion at 0.1 units per kilo per hour. Your goal here is a smooth, controlled glide slope. You're looking for blood glucose to decline by 50 to 75 milligrams per deciliter every hour. If it doesn't drop by at least 10% in that first hour, okay, then you can consider a bolus.
Another massive paradigm shift for 2024 is that mild to moderate, uncomplicated DKA can now be managed safely with subcutaneous rapid-acting insulin instead of an IV drip. It used to be that every single DKA patient automatically bought themselves an ICU bed for an IV insulin drip, right? Not anymore. The guidelines now accept that for mild or moderate cases, as long as the patient has good perfusion, sub-Q rapid-acting insulin protocols, dosed every 1 to 2 hours right there in the ED or a step-down unit, are just as effective. It's incredibly safe, and it saves vital ICU resources. A real game changer.
Section 5. Resolution and common pitfalls. Crossing the finish line safely.
Okay, so you've resuscitated the patient, but we definitely aren't out of the woods yet. Let's talk about official resolution and the critical traps you need to avoid. It is incredibly tempting to just stop when the glucose normalizes. But when is the metabolic crisis officially over? I guarantee you, prematurely pulling a patient off the protocol is one of the most common and dangerous mistakes made in the ED.
The ADA states that all 3 of these specific criteria must be met concurrently. Just closing the anion gap alone, that's no longer enough. To officially declare victory over DKA, the blood glucose must be under 200, and the venous pH must be over 7.30, and the serum bicarb must be 18 or higher. Some protocols also want to see beta-hydroxybutyrate drop below 0.6. But the big takeaway here is that you need all 3 primary markers aligned at the same time, the whole shebang.
You've got to watch out for these major pitfalls, specifically over-aggressive fluid resuscitation in pediatrics. Listen to me. This is the single most common cause of DKA-related death due to cerebral edema. With kids, you absolutely have to pump the brakes. Follow pediatric-specific protocols, use slower correction rates, and do aggressive hourly neurochecks looking for headache or any altered mental status. Another huge pitfall: stopping the IV insulin infusion the second the blood sugar is normal. Don't do it. The acidosis is usually still lingering. You add dextrose to the fluids and keep the insulin running until the pH and bicarb completely normalize. Finally, when you do transition from IV to sub-Q insulin, you must overlap them by 1 to 2 hours. If you don't, the patient will rebound straight back into ketoacidosis.
I also really want to flag that routine bicarbonate is out. Overusing it risks paradoxical CNS acidosis, so reserve it strictly for severe, life-threatening acidosis below a pH of 6.9. Pushing bicarb feels great, like you're instantly fixing the acid-base problem, but it can actually cross the blood-brain barrier and make the brain more acidotic, all while delaying the clearance of ketones. It's a super high-risk move. Keep it in your back pocket only for hemodynamically unstable patients who are right on the brink of collapse. And when it comes to final disposition, a confirmed DKA patient always requires an inpatient transition. It doesn't matter how quickly they seem to bounce back. Even if you correct their mild DKA perfectly with sub-Q insulin right there in the ED, they need a monitored medical floor.
They need comprehensive diabetes education, insulin adherence counseling, and you need time to thoroughly investigate the precipitating cause. Was it an infection, a silent MI, or did they just miss their medication? You can't figure all that out in the ED.
I'm going to leave you with this provocative diagnostic question to keep your guard up during your next shift. If a suspected DKA patient presents with completely normal blood sugar but severe metabolic acidosis, are you prepared to catch the hidden precipitants like SGLT2 inhibitors? Remember euglycemic DKA. Always trust your metabolic labs over a seemingly normal glucose read and trust the protocol. Master these steps and you'll master the crisis. Thanks for joining me on this explainer.